Hello, and welcome to the talk on metatarsal shortening osteotomies. One thing that you will notice is that there is quite a bit of overlap between the three talks that I'm giving today. Oftentimes, you're not just addressing one aspect of these pathologies. It's quite an overlap. You're oftentimes having to address all three of these conditions. Here are the objectives for this specific talk. We want to understand the uses and techniques behind the shortening osteotomies. What are some of the common complications we come across, and what are some ways that we can mitigate these complications? So, metatarsalgia is a term that we often use, and it's very vague, but essentially it's used to describe plantar forefoot pain. And this term, metatarsalgia, is often associated with uh, disruption of the metatarsal parabola, whether the metatarsals are too long or even too short. And I will tell you that I think that this is often overdiagnosed. I don't. I think it's rare to see a metatarsal that's overly long. Same with an overly plantar flex metatarsal. I don't think it's quite often that we see this, but we are commonly diagnosing this, and it's important to address even fat pad atrophy as your more likely problem with some of these real prominent metatarsal heads on your patients. Is there an associated plantar plate insufficiency or tearing? Are you noticing that the toe is uh, cocked up, or is there hyperextension of the MPJ due to insufficiency of your MPJ? That definitely can lead to metatarsalgia. Are there any hammer toes that need to be addressed, or any hammer digit syndrome that needs to be addressed? What about the first ray? Is there a hypermobile first ray? Like we spoke about in the first lecture, sometimes these patients come in and they're describing callus patterns that are painful under metatarsals 2 and 3, and they have a insufficient first ray, extremely hypermobile, and this is creating transfer lesions. And so, addressing this surgically, you need to have that talk with the patient about, hey, well, in order to fix this, we need to fix the bunion. And Aquinas. Aquinas is a huge factor in all of this. And again, like I mentioned, you may need to add this procedure to your forefoot procedures when having to go about surgically fixing this. Your history and physical is very similar to your hammer toe workup. Dermatologically, you will notice callus patterns under 2 and 3, and this is maybe the reason why the patient's even coming to you in the first place. So they may just have a painful callus that won't go away, and this is maybe due to an insufficient first ray, or maybe there is a overly plantar flexed overly plantar flexed lesser metatarsal. You also want to address any plantar fat pad atrophy that some of your patients may be suffering from, especially from our elderly patient crowd. From a musculoskeletal standpoint, you need to figure out where is this metatarsalgia coming from. Under the metatarsal heads, are you noticing a fat pad atrophy? Is there an overly plantar flexed metatarsal? Is there disruption in the metatarsal parabola? Oftentimes, there is a subsequent hammer digit that needs to be addressed. The plantar plate may need to be addressed, and so it's real important for you to perform your Lockman's examination on these patients. Do a first ray examination. Is there hallux valgus component to this? Is it hypermobile? Is the second toe overriding the first toe? These are just things you need to look out for, and these are things that you need to address. Ruling out neuroma is also another problem, and you need to see if there's a positive molar sign. And again, this is going to sound like a broken record, but Aquinas is can be a problem, and it's something that needs to be addressed. Not every single metatarsal head pain needs a while or shortening osteotomy, and maybe this needs to be addressed with a gastrocnemius recession and other procedures. From a conservative standpoint, I like metatarsal pads. Again, for the patient population that's not great for surgery, I find that these do work well for my patients, especially for fat pad atrophy. These are just a little easy to put on for them. They slip them on. There's some degree of compression that can help with some of the swelling that you may encounter, and this can slip into their They can slip this right into their shoe. Uh, there's many shoe modifications that can be made for your patient. Custom shoes, like a 4-foot rocker, certain orthotics with metatarsal pads can help. Even felt padding in the office can be used to create pads. These are all real great. Like I mentioned, Metaral Pack and NSAIDs is kind of my go-to for pain meds. I'm a little hesitant on using cortisone in these patients because, again, you might just be you might make them feel better as far as pain goes, but the deformity itself might get worse because you're essentially weakening these structures with your cortisone. So, like I mentioned, not all metatarsal head pain needs a shortening osteotomy. Uh, you need to address the equinus that might be there. You need to look for plantar plate insufficiency, and maybe these patients need, if it's a chronic condition, maybe they need a flexor tendon transfer to help splint the toe down, and that in and of itself will essentially kind of offload the metatarsal head itself. Uh, Oftentimes, I am addressing all these things with first MPJ fusion or a Lapidus to help stabilize the first ray. Sometimes you get these real chronic patients, real bad crossover toes that need to be addressed with more stabilizing procedures in order to alleviate them from their metatarsal head pain. But like I said, equinus is something that really needs to be addressed because this is probably your bigger problem. So let's talk about surgery. So there's actually a lot of different variations to this osteotomy, and the traditional wile was essentially created to shorten the metatarsal. And the way that the technique is described is you want to try and keep the saw blade as close to parallel as possible with the weight-bearing surface, and then create the osteotomy. Problem with being too parallel is that you can actually ride the shaft of the metatarsal, and that can be very problematic. And so you do need some sort of angle to this osteotomy. So I find maybe 15, maybe even 20 degrees is sufficient for creating a good through and through osteotomy. You typically want to create this osteotomy uh, essentially 2 to 3 millimeters um, from the dorsal cortex itself, um, and that should be sufficient. The other modifications are creating a neck type osteotomy or even a rectangular osteotomy, where you're essentially decompressing the metatarsal head by your shortening, but also you're essentially dorsiflexing the metatarsal head up as well. And this can be fixated with a screw or even a plate. There are plenty of plating options out there now. Another variation is creating a wedge type resection, and in this case, you're minimally shortening, but you're essentially rotating the head up, and bringing cleaner cartilage to the joint itself, and at the same time, you are decompressing the metatarsal head as well. And then there's a double blade osteotomy technique where you essentially stack two number 38 blades, and you create your osteotomy like you would for normal wile osteotomy. And the great thing about this is that you're taking a wedge of bone out, so you're essentially creating dorsiflexion of the metatarsal head with very minimal shortening in this case. So you don't necessarily need to slide the metatarsal head back with this. You can just essentially decompress the metatarsal head with the double plate. I'm sorry, the double blade technique. So here's just a slide depicting that technique. You do not need a very large incision for this. You do not want to over dissect this at all. All you're doing is making a linear incision overlying the toe and the MPJ, and you're essentially pulling the extensor tendon out of the way. You create your capsulotomy, and that's essentially it. You do not have to disrupt the collateral ligaments at all for this, and you don't want to do that. You want to keep this as stable as possible. And so once you have exposed the metatarsal head, you can see here we take two number 38 blades, place them in your sagittal saw, and go ahead and create your osteotomy. Usually angling your hand about 20 degrees is sufficient. Prevents you from riding the shaft. And sometimes you'll notice that you'll notice a wedge of bone that comes out with this osteotomy with the double blade technique, and that's good. That's what you want to see. and then you can go ahead and fixate this with a 2025 screw. Many different options out there: cannulated, solid, even snap-off screws. And like I mentioned, in this case, we're not necessarily looking for shortening. We're just looking to essentially elevate the metatarsal head. You can shorten this if you need to, and oftentimes the metatarsal head will kind of find where it wants to sit, and that's where it should be fixated. Again, very, very important not to overly dissect this. You want to try and preserve the blood supply to allow the osteotomy to heal. Um, and then, depending on what you're doing, you typically will splint this down with gauze, and then they can partial white bear day one. So let's talk about the biggest complication that we have with this, and this is the floating toe. This is what we all dread. This is a nightmare of ours. So why does this happen? There's actually many different theories out there, and there's no one good theory. But essentially, you get dorsal pulling of the intrinsics. The plantar tissues essentially lose their pull and stability, allowing the dorsal structures to even overcompensate. And then there's some theories about you lose the tension of the plantar fascia because if you remember, the plantar fascia actually inserts as a continuation of the plantar plate itself, and so by shortening the metatarsal, you may be losing tension of the plantar fascia itself. So there's many different theories as to why this happens, but essentially, uh, there's loss of stability at the joint itself, mainly in the sagittal plane. But there are ways and techniques that we can use to address this, and so that comes with the osteotomy modifications. When you're doing just a traditional wile osteotomy, if your blade is too oblique, what will end up happening is, of course, you're going to shorten the toe, but you may actually plantarly depress the metatarsal, creating more of a problem for the patient. There's more plantar prominence at this point. And so if you look at some of the modifications we just talked about, whether that's um, essentially doing the double blade technique where you take a wedge of bone out or you derotate the metatarsal head. These are ways that can essentially prevent shortening, but at the same time, sort of elevating and decompressing the joint. Uh, Oftentimes, you're having to address the PIPJ as well, and PIPJ fusion may be needed. However, uh, if if a PIPJ fusion is performed, this can actually cause more of an issue for your patients at the metatarsal phalangeal joint level because you get retrograde forces that will essentially uh, cause pressure at the metatarsal phalangeal joint. So to offset this, this is where the flexor tendon transfer works really well. So you do your wile osteotomy with the PIBJ fusion and then a tendon transfer on top of that to prevent the toe from floating. Extensor tendon lengthening does work really well. What you may need to do is once you perform the wile osteotomy to prevent a floating toe, if you're not doing the flexor transfer, you can lengthen the extensor uh, tendon itself. You can also dissect the extensor hood, which may be contracted, and that will allow the toe to sit rectus. And then there's techniques on how to prevent scar tissue prevention. Scar tissue can also create your toe to float, and there's some options we have that we can talk about here in just a second. So again, a recurring theme here is a flexor tendon transfer. I do often use this with my my lesser metatarsal osteotomies. It's great for preventing the toe from elevating in the post-op period. It works really well for your insufficient plantar plates. Like I mentioned, I use the Girdlestone-Taylor maneuver. However, there are many different techniques out there that do work well, and I encourage you to add this to your procedures when performing the wile osteotomy. And this slide is what we used in the last presentation, but again, just is just sort of depicting how I harvest the tendon. And like I mentioned in the last presentation, with being able to crisscross the tendon, this allows you to dial in your correction, whether the toe is drifting medial lateral or just extremely subluxed in the sagittal plane, this really allows you to dial in that correction. We did talk about the extensor tendon lengthening, and may need to be performed with your procedures to help mitigate uh, a floating toe. Um, the idea behind this is that it removes any further dorsiflexion type forces across the MTP. And so you're essentially weakening the extensors to allow the toe to sit well. Uh, and Again, if you're not going to perform a flexor transfer, then this is something you need to really take into consideration. And there are times where I have to do both, where I do perform my flexor tendon transfer, but also I'm lengthening the extensor just to really mitigate this floating toe problem. And scar tissue. Uh, it's always a problem with patients, and if too much of a scar builds up, this can actually cause the toe to also elevate. Uh, so typically what I will do is from a more of a post-operative standpoint, we will splint these patients in a plantar flex position, and I will continue to splint them in this position for several weeks, even after sutures come out. Sometimes we will send these patients to physical therapy to help mobilize the tissues, and I will have them also do some mobilization techniques at home. Um, in the operating room, other options are you can drive the KY across the MTP uh, and sort of hold them in a plantar flex position. It can be problematic if you have a screw that might be in the way, but you can work around that. Um, and then, of course, your dissection also plays a big role in how much scar tissue may form on a patient. So I urge you to not overly dissect these joints out. And again, patient education and just discussing with them, hey, everything can go great, but there is this chance of a floating toe, and that's something that you need to talk about with these patients. It's a pretty popular paper, Highlander, 2011, foot and ankle specialist, looked at 1,100 while osteotomies, and they found 36% floating toes. It's quite a bit, with 15% recurrence of the symptoms, 7% with transfer calluses. So, this is data that you really need to keep in mind when performing this procedure. It's simple to perform, but there can be some complications. Even if you do take the time to try and mitigate these with the flexor transfer, extensor tendon lengthening, there's no guarantee that these toes will sit straight. There still may be floating toe. Another paper here looking at 89 while osteotomies, again, pretty high percentage of floating toes, 33%. However, 80% of these patients stated that they would repeat the procedure. Biggest complication for them was stiffness. Just to recap here, we found with the literature that there's an 80% satisfaction rate with the while osteotomy, and anywhere between 15 and 36% will suffer from floating toe. Many theories on why there's a floating toe, but essentially, uh, when you depress and overshorten the metatarsal head, there is dynamic instability at the MTP, specifically in the sagittal plane. Of course, there's ways that we can counteract that, and we do that by modifying our osteotomies. You may need to perform a PIPJ arthrodesis. Just remember that with the PIPJ arthrodesis, this may actually enhance the floating toe due to retrograde forces. And so you have to figure out a way to bring the toe back down, and typically that's done with a flexor tendon transfer and or extensor tendon lengthening. And then we talk about scar tissue prevention, which it will entail you splinting the toe down, having the patient massage the scar tissue in the postoperative period, starting early range of motion exercises, and then just patient education. I again want to thank my colleagues in Indianapolis for allowing me to use some of our old x-rays from fellowship, and thank you.